Welcome back, friends, to episode 5, our final installment of the Cairn cast on Marshall Allen's book, Never Pay the First Bill. As usual, Taylor Rogers.
Rich Haney.
And today we have a guest that we're really excited about. We have Dr. Chris Larson from here in Austin, Texas, Euphora Health. Dr. Larson, good to have you.
Yeah, thank you guys for having me on. I'm excited about this. I'm always excited to talk about direct primary care.
Yeah, well, I will start off and just say, I've actually been a patient of Dr. Larson's here for, coming up on close to a year. And the advanced primary care model has been just incredible for me. I've seen amazing benefits and really enjoyed it. So excited to dive into this. I guess as a way of getting started, Dr. Larson, tell us a little bit about your background, as a consultant moving into medicine and just kind of how that whole thing took off for you.
Yeah, sure. Yeah, so I have a degree in finance from University of Texas at Austin. From there, moved over to Houston and worked in energy investment banking. And then pretty quickly, kind of seeing what that work-life balance was going to be like for, the next 30 years, decided it may not be for me. And then moved over to trading natural gas options right about the time that the small company called Enron went kablooey. So that dried that market up at that same time and kind of left me twiddling my thumbs, which is that's not a very good place for me. I like to be have my mind active and focused on things. And so I really started to think back to some time in undergraduate where I was helping at-risk youth. Kind of decided I wanted to change my career and really focus on something where I could marry helping others with kind of, lifelong learning. Thought about teaching, coaching, and medicine, and finally ended up deciding on medicine. Went back to medical school. I chose an osteopathic medical school because it really fits my philosophy, hand in glove, in the sense of really kind of trying to help people get to the root cause of their problem. And trying to, these days, that's often chronic disease based on how we live our lives. And so as opposed to kind of always depending on, pharmaceuticals and surgeries, I wanted other tools to be able to help my patients. And I thought osteopathic medicine and osteopathic school really allowed a broader approach to that. And so went to osteopathic medical school in Fort Worth. Then went to San Antonio to do my residency. And even while I was in residency, I was already looking for a different model of care. And at that point, I was lecturing to our other residents about what was kind of a half concierge model. Robin Hood, I think is what we were calling it back then. So they had a concierge model with concierge prices. And that was half the population of the people that they would take care of. And they basically took profits from that side and they subsidized the other half of their population that couldn't afford concierge prices to try to give everybody great care. I thought it was a great idea. I just didn't think that was going to change the healthcare world. And so didn't start that coming out of residency, which I ended residency in 2010. And then somewhere around 2012, 2013, I started reading in the lay press about direct primary care. And the model is simple enough. And with my finance background, just kind of backwards engineered the ability to open my own clinic. And so I don't know, maybe there were 200, 250 direct primary care doctors in the nation at that point. And it's really been growing rapidly since then. We're still a niche product within the healthcare system. But you are finding that many more primary care physicians are going directly into direct primary care or opting out of their insurance-based practice and moving over.
That's interesting. So one thing you said at the beginning of that triggered something we talk about a lot, which is, doctors, most physicians didn't get into this business to make money. There are easier ways to make money. It
Right.
sounds like you were in one of those easier ways to make money doing finance and, derivatives and so forth, within the energy space. And this was really kind of almost a missional calling to go and do something that was good for people. So we're always encouraged when we talk to physicians that there's this kind of, just very optimistic view of humanity almost.
Yeah, absolutely. I was going to ask a follow-up question on that two-part. So your patients can come to you for stock options and also to be able to take care of them physically and financially, right? So I got, is that correct?
Even I apparently
You're
don't
giving
take my
Taylor
own
some
financial advice these days. So I don't know that I would suggest that you take my financial advice either. Everything I've got is in index. So if you're happy with index, well, then I could advise you.
Perfect.
Hey, as long as it's going up, that's all I care about. The other question I was going to ask was your support system, like your family and stuff. When you made that's a pretty big career shift, right? Going from finance to the medical world. Did you have people like, whoa, what are you doing here? I mean, you're a young guy. You didn't know which way life was going to take you, obviously. And that's, I never thought I'd be in insurance. So just kind of curious, like what that was like, because that's a big shift.
Yeah, I wouldn't say, I've always been relatively headstrong. And I think my mom says that I was born basically an adult, I guess making adult decisions even, younger. And so I really don't even feel like that was a decision. Like I just had to do it. And so I quit. I lived off of savings for 2 years while I went back to University of Houston undergraduate, which was a really odd change, going back from kind of a professional area back to undergraduate, and lived off of savings while I was taking the science prerequisites to get into medical school, and loved it along the way. But I wouldn't even classify it as a choice. I just felt compelled to do it.
That's awesome.
So let me ask you this: now that you've been in it for several years, in the DPC setting, what do you feel like are the greatest limitations, as well as the positive things about the relationship?
I would say the limitations on a kind of a more micro scale, and you're talking from the physician standpoint, or
Correct. Yeah. No, I know from a patient standpoint, there are very few limitations as to what I would get from a normal primary care doc. But I guess for system wide, what would you say are limitations?
Yeah, I would say that system wide, the biggest drawback that's often discussed is, when you go from an insurance-based primary care practice where your panel size, which is basically how many patients might you see in a year, and that could be anywhere from 2,500 to 3,000 patients in a year, you really cut back to somewhere between 600 and 900 if you're dealing with individual patients. We can get into specifics when you start talking about working with employers as well, because then you're being paid for a group of people. And some of those people are going to be marathon runners and maybe never call you. And then other people are going to have lots of chronic disease and potentially utilize a lot of your time. But over the breadth of that group, maybe you can kind of have more people on a per unit basis than you could just private members that come in. So if we're talking private members, it's maybe a third of what you would take care of in an insurance-based practice. So that's often mentioned as one of the drawbacks if we had lots of primary care physicians at once move to direct primary care. But just things to think about in that scenario is direct primary care is drawing primary care physicians for a reason. It's just a better lifestyle, and it allows doctors to treat patients in a manner that they want to. I don't have to interrupt people. I can let them, speak for more than 8 seconds in a row. I can really get to know them and their family, which, when you think about what a primary care physician kind of sacrifices, my wife is a primary care physician as well. And, she sacrificed her 20s to go to medical school and to go to residency, right? Everybody else was going out and partying. And she was either at the library or she was working 80 hours, 90 hours a week at the hospital during her 20s. So she really has sacrificed something to get to this point. And so the quality of life that you can obtain in direct primary care, in my opinion, is really kind of worth this. But at the same time, we've got other primary care physicians that have gone to urgent care and they're working at urgent care, or they've gone to the emergency room kind of in rural areas and they've done that, or they're working for insurance companies and they're not seeing any patients at all. That potentially, if we offer them a job that allows for a better quality of life, maybe we pull all of those physicians back into the primary care system. And then long term, maybe we pull in some of the medical students that are now going into other specialties. Maybe they choose primary care as a specialty to go into the future. And so that's a way that I think that we can kind of make up for that fault in the system. And there are others as well that kind of get into a more nuanced conversation, meaning kind of allowing the physician to practice at the top of their license, I do a lot of education for my patients when it comes to how to change your lifestyle. Once a well-educated person hears my spiel, 5 or 10 times, could they reproduce it for most people that need that conversation? Yeah, they could. So maybe they could kind of offload some of that on me and save me for when people are having a lot of barriers to implementing these changes. There are different ways where we could, I think, cover that same panel size, but still offer great care like we do in direct primary care.
So the cynical perspective would be we already have a shortage of primary care physicians, and switching over to reduced panel sizes because of this direct relationship would only exacerbate that problem. But the optimistic view of that is, yeah, but once we get people engaged with proper primary care, they're going to have fewer downstream needs for one, but also it sounds like you can have maybe mid-level trained folks that triage a lot of that everyday occurrence type stuff for folks who are, relatively low barriers to compliance.
Yeah, I think there are a number of ways to skin this cat, but kind of what we've discussed are a couple of ways where we might be able to make up for that shortfall.
Excellent. So
I was going to ask, are those mid-level positions, is that PAs, physician assistants, is that FMPs? What does that kind of look like?
I think it kind of depends on like how you want to approach it. I'm a fan of what I would call kind of optimized Medicare Advantage primary care. So we're talking, ChenMed, CareMore, these types of organizations where there are a lot of non-physicians that are available to take care of these patients. And the physician is kind of tasked with making a diagnosis, making a treatment plan, and kind of being the tip of the spear to say, hey, we need this person's help right now in this particular situation. We need this person's help right now in this other situation, and help kind of guiding a team. And so, if we're talking about lifestyle change, then I think maybe somebody that's kind of IORA is a group that's doing something similar. And they basically retrain people that have been in the service industry to do some of this type of thing, or they retrain social workers. And so there are a lot of lifestyle coaches out there, but I think some portion of this could be taken care of by people that kind of classify themselves as a lifestyle coach in some form or fashion.
That's really interesting. I think empathy, it sounds like empathy is kind of the secret ingredient to all that, People feel understood, they're going to be more likely to comply. So I want to switch into one of the quotes from Never Pay the First Bill, which again was kind of our muse for this series, stated that according to the Washington Health Alliance, in a single year, more than 600,000 patients underwent treatment that they didn't need, costing the system $282 million. More than a third of the money spent on healthcare services went to unnecessary care. So with a patient collaborating with a primary care physician, first of all, I guess starting off, does that statistic seem reasonable to you that we could waste, $250 million just on stuff that is low level but not needed? We touched on this in the episode we recorded last time. There's no such thing as a good price on something you don't need. Do you think that that's a reasonable metric right there?
I certainly wouldn't say it's unreasonable. They've kind of have to look at things and make some assumptions at high level to come to these numbers, but seeing it on a more granular level, I think there's a few things to discuss of what might lead to this kind of behavior. And kind of the main buckets to me are kind of siloed health information and kind of a lack of a relationship with the patient. And so within lack of a relationship with the patient, where, these days for your insurance-based primary care physician, as long as you can make an appointment 3 months out, you can see your doctor. But if you can't do that, well, then you're going to see one of their partners or their PA, or you're going to go to urgent care or a minute clinic. And so we've kind of fractionated primary care, right? Like your doc can take care of your chronic issues, but anything that's more acute than that, someone else is going to take care of this. And they may not always have your health information at hand. And at the same time, they haven't built the relationship with you to know, what are you interested in? You're here for this acute issue, but are you the type of person that says, hey, I just want you to make sure I'm not going to die today. And if I'm not going to die today, I don't need a full court press on medicine and diagnostics and all these things. The person that's sitting in front of you doesn't know that. And so, defensive medicine is this concept of maybe the provider does too much from either a treatment or a diagnostic standpoint, because they want to, one of the goals is to limit the likelihood of bad outcomes. And so, in this is a double-edged sword, right? Because certainly we're going to increase the chance of potential bad outcomes when we use medicine that we shouldn't. And even some of the diagnostics have potential downsides as well. But then, yes, there's certainly the cost. And so defensive medicine does happen. And then there are even more acute situations in the hospital where long ago, sometimes your outpatient doctor would follow you into the hospital. And even if they weren't the ones treating you, certainly they might make social calls and talk with the doctor that's treating you. These days, you may not even get the same doctor day after day. It's much more shift work based. And so it's kind of team based, and the relationship just isn't there like it used to be. And so I think that like lends itself to some defensive medicine. And then at the same time, they don't know your history. And so they're kind of having to make things up on the fly. And that often leads to a situation where, with siloed health information, they have to reproduce tests, and they have to reproduce your health history in some point. We can't, it's sad to say, but we can't always count on the patient to give a full and thorough health history. And so a lot of times we have to reproduce that with tests and diagnostics when we need that in the moment, and when we can't count on obtaining that from other parts of the healthcare system. And so I think certainly there are times when we're reproducing lab tests and imaging and that kind of thing where it's not needed. It's been done within the last couple of years. It's just not easily at hand for the doctor that's trying to care for you in the moment.
So I'm going to expose my lack of technological awareness, but it sounds to me like if there was some sort of continuous record of medical records that everybody had access to, it would curb a lot of this overutilization, unnecessary testing, things of that nature. Is there anything coming that you're aware of in the world of blockchain that would, organize this in such a way that this happens far less often?
There might be nothing that I've heard of.
Okay.
I think there's so much regulation within the industry that often, somebody that's interested in technology puts their toe in the water of healthcare and then pretty quickly say, oh, this isn't the area for me. There's just way too many barriers for me to kind of be able to build something that could easily be scaled. And so, it's entirely possible, but I would say based on what I've seen from technology historically within the healthcare system, there's just a lot of barriers when it comes to HIPAA and high tech to kind of make that type of system work.
And it seems like there's not very much incentive either, for a lot of the players that might fund a project like that to curb that. So, no, that's great. So you touched on this a moment ago, and have you ever worked in a hospital setting as a kind of a hospital, internist?
Not outside of residency, I have not.
Okay, great. Then I'll kind of skip that question, because I was going to see, and we'll cut this out, but I was going to see if there was any kind of administrative pressure for, running things and the fear of getting sued and malpractice, med mal, and all that sort of thing, because I've heard those stories from others. So we'll kind of skip over that.
I mean, the pressures and the incentives are not dissimilar, outpatient versus inpatient. So whether you're, often these days you're an employed physician. And so someone is managing your schedule and the number of patients that you're going to see on a daily basis. If you work in the hospital, well, then really there's no set schedule, right? Like, you've got this number of patients to see. If you want to get out of here and go see your family, you need to do it within some set time. Within the clinic, we have a schedule, but the employed physician is not in control of that, other than, hey, I get 2 breaks a day. I could tell you where I want my breaks. But other than that, some administrator above them is saying you need to see on average 25 patients a day, or on average 30 patients a day. And for established patients, we're going to give you this much time. For new patients, we're going to give you this much time. And so for the most part, the doctor is just showing up and doing what an administrator wants them to do from a scheduling standpoint. And so then when you really start talking about incentives of, get to the granular level, is what medication is the doctor prescribing? What diagnostics are they prescribing? When are they referring? When are they not? Lots of this comes down to they're just simply trying to stay on schedule. because they know if they're late the rest of the day, they're going to have upset patients. They're going to be working later into the evening and not be able to get home to their family in time. And so, you know, when you read about this outside of healthcare, you can kind of think that, oh, there's some grandiose system here making doctors kind of do all these things. It's much more myopic than that from the doctor's standpoint. They're simply trying to get to the next visit on time. And lots of times what happens there is, you know, you have 15 minutes from the doctor's side, you have 15 minutes scheduled for the visit. Your medical assistant has taken some portion of that time to get the person ready. And then you have your time with the patient. And then you have to leave the room and document a bunch of things and send prescriptions and send referrals. So that's how we take a 15-minute visit down to I'm in the room with the patient for just a few minutes to a few seconds, because there are other things to do for the patient. And if your goal is to be able to get on to the next patient in time, well, if this requires, you know, 20 minutes to do some type of skin biopsy, well, then it's just easier to send that to the dermatologist, even though you, as the primary care physician, are trained to do that same biopsy.
That's probably the most compelling case I've heard from DPC, quite honestly, is just understanding the schedule.
Yeah, absolutely. And I think that contributes to part of the waste, right? Like, you don't need to send somebody to the dermatologist when you're trying to do it, but if you have to adhere to this strict schedule, obviously that, you know, that just, it all just kind of adds up. It layers on top of each other. And I know from personal experiences, every time I go to the doctor, especially when I was younger, you know, strep throat, I'd see the doctor for a minute at most, and we'd be on a high deductible healthcare plan. And my mom would say, like, oh, it's $150 for that visit. And like, unbelievable.
So let me ask you this: when you have the luxury of time in your model, how do you collaborate with members to determine when a specialist referral is necessary? Because obviously at that point, you've probably exhausted most of your, you know, what you're trained in.
Yeah. So this model really allows me just a lot more time to spend with my patients and on my patients. Meaning, you know, oftentimes, and this depends upon the number of issues that I need to discuss with somebody that's new. You know, I might be able to spend an hour and a half with them at the very beginning to really kind of allow them the time to adequately explain what's happened in their history, and for me to, you know, without interrupting them, kind of delve into questions to clarify, hey, what's happened here and what's happened there. That really helps me solidify that relationship. So in the future, when I do offer virtual care, they're much more trusting of my opinion, my ability to diagnose things remotely, because I've just spent so much time with them initially. But it also allows for kind of more time spent in follow-up. You know, if for a strep throat, I mean, from this side of the fence, you know, I usually don't need a whole lot of time to diagnose a strep throat. At the same time, I can certainly understand when you get a minute of a doctor's time, you know, it's frustrating. You get a $150 bill for that. But there are other times when you're diagnosing something that's difficult to diagnose, that there's many different factors going into nebulous symptoms that you just need a little bit more time. And so this model allows me that, because I have fewer patients that I have to take care of on a daily basis. I can allow for gaps in my schedule to fit people in acutely. And then this gives me the time to kind of go do extra research if I need to. So as a primary care physician, I'm a specialist in common problems. If it's an uncommon problem, that's certainly when I need a specialist to weigh in. But that doesn't always mean that you need to go somewhere, that you need to go to the specialist office. So I kind of view this like a funnel. So at the top of the funnel is patients always start with me, hopefully. They have a financial incentive to do so, and we have a relationship established. So they want to talk with me first, and they trust my opinion, and they trust me to say, hey, this is outside of my wheelhouse. But so let's start there. And so certainly I should be able to do all of the things that your insurance-based primary care doctor could do. But I have extra time, so I could also do that biopsy that we just said that insurance-based doctor is probably going to refer out. But what if it's a type of biopsy that I've never done before? Well, I have the time to go research that and study on my own, or call a dermatologist and say, hey, guide me on how to do this on my own. So I can even do some things that I've never done before. or I have the time to go read about things that either I've never dealt with before or it's been a really long time. And so I've made diagnoses in this model that there's no way I ever would have made in an insurance-based model. I've diagnosed scurvy. I didn't do it the first time I met the patient. It took me a little while. But I was able to iterate on, okay, here are your issues, here's your history, let's do these labs. That didn't tell us the answer. Let me ask you a little bit more history. Okay, let's do these labs. And finally, we were able to get to the answer. There's no way I would have been able to do that in an insurance-based model, and probably that patient would have ended up floundering with a number of rheumatologists before getting an answer, if they ever did so, because that rheumatologist is under the same time pressure as every other doctor in the system these days. And so after that, let's say that I've done all the research, that I've asked for, we used to get what are called curbside consults. And so curbside consult is the primary care doctor used to go to the hospital, park in the doctor's parking lot, and at that curbside would run into the cardiologist who's taking care of the same patient as the primary care physician. And as opposed to making the patient go back to the cardiologist and see them, they would say, hey, Mrs. Jones is experiencing X and Y and Z. Can you tell me what I should do for the patient? That's a curbside consult. That's gone because the primary care physician no longer sees the cardiologist at the curbside. But now there are some third-party systems that would allow for that. Certainly, I can call local physicians and get them to weigh in on this. So that kind of extends the amount of specialist care that your primary care physician could offer. And then even in the situation where the patient really does need to go to the specialist office, I've either obtained enough information from the specialist to get extra testing or get extra lab work and put it in the hands of the patient so when they show up, they can potentially get everything taken care of in one visit, as opposed to showing up with nothing in hand. And the specialist says, I need this diagnostic, I need that lab, I'll see you in 2 weeks, and then we can kind of move forward.
What do you find is the biggest barrier for people? Is it the monthly subscription fee? Is it just feeling like they're invincible? Why do you feel like more people, don't sign up? Or people that I'm sure you've met people in the past who were really compelled, thought this was a great idea, but then didn't pull the trigger. What do you think is the most common objection there?
Yeah. So I've been doing this for a while, and certainly at the very beginning, one of the biggest barriers was people were just skeptical. It was too good to be true. And they had never heard anyone else doing this. They had never read about it. And so when your first thought is, how are you going to steal my money? As you can imagine, it's hard to convince somebody to kind of, plunk down their credit card in your software system to keep paying you on a monthly basis. I think more people are hearing about it from their friends and family, and maybe they've read some articles, and there's some kind of social media influencers that have discussed this to kind of expand the knowledge of the layperson about this. These days, what I find is even when people hear about it, there often has to be kind of two things happen at the same time for them to pull the trigger. And that is, one, they need to have a health issue. For the healthy person that says, I never have to go to the doctor, they don't want to pay. You don't want to pay for Netflix if you never watch movies. And so they don't want to pay the monthly fee if they feel like I'm not going in. So they need to have a health problem, and they often need to be unhappy with the current healthcare system. And so when you combine those two things, that's when people start to join, and that's individuals. So certainly I work with small employers who have no insurance wrapped around what they offer to their employees, and then I work with larger employers who kind of tightly integrate direct primary care into their healthcare plan. But from an individual patient standpoint, what I find these days is often they need that health issue, and they need to be upset enough with the current healthcare system that they're willing to make a change. Because, and I don't want to sound like I'm wearing a foil hat here, but I think that we've all kind of, we're in the matrix, so to speak, right? Like we don't know what we don't know, and we're used to this system where if you don't plunk down your insurance card, you don't want to use it because, gosh darn it, I've paid for this and I want my benefits. And so there's a little bit of a mindset change that has to happen. And so a lot of people that are coming into the direct primary care model right now are at the fringe in one way or another. They're either desperate from a healthcare situation or they're desperate from a financial situation. And that allows them to consider this as an opportunity.
So I want to launch into something, and I'll start, and I promise Dr. Larson's not paying me for this. But kind of my transition into DPC was very similar to what you just described, where I was already upset with the healthcare system. I deal with it every day. It's what we do for a living. But I was listening to a podcast of all things. It was a golf podcast. And the host of this pod, or I guess the guy being interviewed on this pod, said he was playing in a PGA Tour event and was walking up the 18th fairway, and he felt like his grandmother was giving him a really weak hug. And it turned out he was in his mid 30s, and he was having a widowmaker heart attack there on the golf course, had no idea. They load him on a stretcher. He ends up being fine, but it gave me this kind of epiphany that I was like, whoa. He described his lifestyle, and it was me to a T. He ate red meat a couple days a week, drank alcohol occasionally. He was a professional athlete, walked a lot, did all those things, but he had some heart disease in his family. I've had multiple relatives on both sides die of heart attacks and so forth. So listening to this, I was just like, oh my God, I've got 2 young kids. I need to know where I am in my, health journey. I need to see as my numbers change. I need a doctor that's going to help me. And I looked at it and I was like, this is less than $1,000 a year. I spend $1,000 on all kinds of stupid things throughout a year. So to have a doctor in my pocket, it was just such a no-brainer. And I've got to say, I had pretty high expectations for what I would be getting, and they've been blown away. I mean, what you've been able to do just for me personally, a guy who's relatively healthy, I've been blown away by how much I've utilized it. So let me, I guess, transition that into the question of when someone hears that and they say, okay, I'm kind of sold on this. I think it sounds like a really great idea. How would you recommend that they go about finding a primary care doctor and, evaluating whether or not that's the right relationship and going into MD versus DO versus, whatever?
Yeah. Yeah. So, I mean, obviously I'm biased towards direct primary care. So I think that you're going to get the best care, mainly because, the doctor is not necessarily better than they would have, their colleague in insurance-based medicine. But Dr. A is a better doctor for you in direct primary care than Dr. A is when he's in an insurance-based clinic, because he just has more time to spend on your care and spend caring for you. And then on top of that, the incentives of, classically with insurance, the only way that your doctor could take care of you was face to face, because that's just the way that they got paid. So you're being forced to come in every time you need something, even if that care might be better provided virtually. And so I would certainly make that suggestion for chronic disease care. Like, we just need more time talking so I can have a better understanding of you and I can provide more education. Why waste your time driving to my office and driving home when we could spend that time talking? So just stay home and let's get on a phone call or a video chat. And I think that the care that you get would be more productive. But as far as like assessing what's the best doctor for me, so my own bias is look for a direct primary care doctor. And then within that, there's still gaps across the nation from a geographical standpoint on where you might find a doctor. From my own practice, I'm happy to provide a lot of virtual care. I feel comfortable 85 to 90% of the time doing things virtually. That doesn't mean the patient's always comfortable with that, but I'm comfortable with that. And then, like I said, certainly in a chronic disease scenario, I think it may be superior potentially. So if you're interested in direct primary care and there's nobody around you, maybe search for somebody in your state and see if they offer virtual care. And even if you might have to go to their office once a year and you live out in the country, it's kind of like going to the mall once a year or twice a year. That's not that big a deal, right? You just set out a day and you do it. Well, if you only have to do the same thing for your primary care physician, it's really not much different from a travel time scenario. And then from there, you might just make sure that it's a good philosophical fit. In part, I chose direct primary care because I want to be able to institute a conservative medical philosophy. If I can help you change your risk by helping you to change your lifestyle, I'd certainly rather do that than start with giving you medicines. At the same time, I'm the type of person where I'm going to meet the patient where they are. So if you're a believer in better living through chemistry and you have no desire to change the way that you live your life, okay, that's all right. I can help treat you too. But for those people who say, look, I really want to kind of focus on lifestyle change, this model allows me to do that. So if that's the type of thing you're interested in, maybe just ask for kind of a 15-minute meet and greet with a physician and see if they're aligned. From a DO to MD standpoint, I think there's just so much crossover in philosophy and capability that I don't see often, and I'm painting with a very broad brush here, right? Certainly there are differences between physicians. But often they kind of practice in a very similar manner. There are some specialized osteopaths out there who take a more hands-on approach and do the hands-on treatments that we were all trained to do in school. I'm not able to, just from a timing standpoint, not able to offer those as much these days as I have in the past. But if that's something that you're interested in, that's certainly something that I would ask about as well.
Very good. So it sounds, I think we've covered this, by and large, but is there anything that people are surprised by when they enter in, or what expectations they should have kind of for their care journey? And I guess to tee that up, I was shocked when you told me that 90% of your visits, roughly 90% of your visits were virtual. I thought you were crazy. I was like, dude, I live 5 minutes from your office. I would much rather come in when it's convenient. I don't think I've come to see you one time. We talked via the app and, on the phone when we need to, and I found that to be really great. But what expectations are typically set and broken for people?
Yeah, so to just kind of follow up on what you said, part of that is coronavirus, and so just because of personal issues, we're pretty strict trying to protect patients and staff and that kind of thing. So certainly people are still coming in the office, but if I can walk you through a shoulder exam and get 99% of the information virtually that I could get by doing it on my own. And these days, with a shoulder exam, even if you need to come to me for me to do it, I'm probably going to walk to your car and do it in the parking lot. Why make you kind of leave the office, take half a day off, drive over to, in traffic, get upset about that in Austin, just for me to gain no extra information? And so as far as like expectations, people don't know what they don't know. The healthcare system is opaque. I think pricing is certainly one of the things that people are often surprised by. The model in some sense is part Netflix, part Costco. The Netflix kind of membership model of eat all you can if you want to binge on movies, just like if you need to binge on healthcare in a month, there's no extra cost for that extra time of mind that you utilize. But then the Costco portion is, basically we make our profit off of the membership and we try not to make a profit on anything else. So wholesale price labs, wholesale price imaging, no cost point of care testing, no cost procedures like dermatology procedures, removing toenails, EKGs. Where in the traditional health insurance system, there's a lot of profit.
Nickel and diming.
Yeah, well, what I would say is profit shifting and kind of lures into the system, so to speak. So, EKG, for an example, the only kind of variable cost there are the stickers that I utilize to put that on your chest. I think I've priced the stickers out and they cost 89 cents. I wouldn't be surprised if an insurance-based practice charges $100 or $150 for that. We don't charge anything.
Right.
And so, they get paid so little time for their visit that they have to make up for it in other ways. And as a part of that, it's overcharging for things like EKGs. And so I think when people start to understand, like, oh, when I pay cash in some form or fashion for imaging or for procedures or for labs, it really is relatively affordable. I have a lot of service industry workers who, through kind of subsidized care from the employer, have access to us, but don't have any insurance wrapped around them. And, certainly they're concerned about going broke from imaging costs. But if I can get you an X-ray for $35, an MRI for $250, when they hear these numbers, certainly it's not, oh yeah, I'll definitely do it anytime I have a minor injury. Certainly they still have to think about it, but it's not going to break the bank like the numbers that you might expect, even using insurance these days, of $1,000, $1,500 MRIs after plunking down your insurance card. So I think the pricing of healthcare when you pay on a cash basis really surprises people. And then just how much care you might expect from a primary care physician that is unchained and allowed to provide as much care as is within their kind of breadth of knowledge and skill.
I can definitely attest to the pricing transparency kind of blowing your mind. I had a MRI that you said, hey, the cash price across the street's $250. I can schedule it for you. And I said, well, let me call my insurance company first. I have a major medical plan, with my prior employer. The best price in town was over $500. So for the benefit of accumulating toward my deductible, I was going to pay double the price that you just had for me across the street. So anyways, I can attest that that's definitely something that's well on the water. So I know we're getting close to time here. I wanted to wrap this up by, I guess, just first of all, thanking you, for your time and for being here with us, and also get your final thoughts on where do you see this model moving? How do you see it evolving? How does DPC kind of fit into the healthcare ecosystem of the future with where we're going?
Yeah, I continue to see individual doctors kind of opting out of the system, so to speak, to save their emotional state, to save their family life, because they're just, when they poll primary care physicians in the insurance-based system, 55% of them will indicate that they're depressed or burned out. Like, as a patient, is that really who you want treating you? And from my standpoint, I'm trying to, in part, create a model where I can help my friends and colleagues get out of that system. And so I continue to see people, primary care physicians, opt out of the system. And then you're starting to see more employers utilize this. We've even had a medical school, University of Houston Medical School, go out and get a grant from a local group to start utilizing direct primary care from lower socioeconomic status residents within Houston. So basically, sounds like they're getting subsidized care in some form or fashion. So I think there are some experiments going on to utilize this, and it's kind of sprouting. We talked about Medicare Advantage style primary care. Other groups are leaning towards what they call advanced primary care, which has different types of funding. And so I continue to see this grow. Maybe not exponentially. This really has taken a whole lot more time than I expected it would when I first started with this. And there are reasons to explain that, both from the doctor side, where doctors are often risk averse and they come out of medical school and medical training with lots of debt. And so kind of having that guaranteed paycheck on day one really is beneficial. But also from the payer side. And so I think there's still barriers to overcome. Things are moving more slowly than I would have expected for direct primary care, but still growing.
That's great. Yeah, one thing I think we're hoping to see expansion of is we're working with a maternal fetal medicine doc right now that reviews all of our complex high-risk pregnancies. And I would love to see the further expansion for, spine and joint, and just different areas where you have a specialist who's got this unbelievable career, has seen everything, and say, dude, go live in the Bahamas and review these cases virtually, and when Dr. Larson has a complex, issue, let us tap in, review all the case files, and give us your expert opinion, because that's what we need is to get the diagnosis right. And then get one of these young whippersnappers out here. They can do the surgery. They've got fresh hands and eyes and all that sort of thing. So you had something, Rich?
Yeah, I was just going to ask, how do people engage with you if our listeners or, folks we're talking with? I mean, what's the best way to reach out to you to even do that 15-minute consult to see if there's any synergy?
Yeah, so through our website, which is euphoriahealth.com, that's EUP as in Paul, HORA health.com. We have a contact form so they can send in a little question if they would have there. We got our phone number on the website. We've got 2 clinics, so depending on which one you want to call, it would be a different phone number. And then if you're looking for somebody closer to you, there's a couple of different websites you might consider looking at to see if you can find a direct primary care doctor closer to you. There's dpcalliance.org, which is a physician-run, physician-led group of direct primary care doctors. And then if you just type DPC Frontier Mapper into Google, that would probably bring you to another spot where these are self-reported direct primary care doctors. Some of them are individuals, some of them are kind of working with employers, but self-reported direct primary care there as well. And so contact us by phone or message on our website, or find a local doctor for yourself on those 2 websites that I mentioned.
And one last thing I wanted to ask you. So you work with both employer groups and individuals. People can come to you regardless of their setting or arrangement as long as they're in the state of Texas. Is that correct?
Yeah, that's right. So these days, physicians are able to practice with their license is state-based. There's some states that have come into a consortium and they've said, hey, if this physician is licensed in this state, we're going to allow you to be licensed in that one. As of now, in my understanding, Texas is not a part of that consortium. And so for me to be able to take care of people that reside in other states, I would have to get other licenses. But we offer we offer what I call brick and mortar memberships for those people that want the ability to come into the office, and those are a little bit higher priced than virtual only memberships, which are meant for people that live remote from us and would never be able to access us. And I've got individual patients that live remote within Texas, West Texas, Dallas, Houston, and I've also got employer-based patients where they have an insurance around what we offer, but they live in Lubbock or they live in Houston. We offer virtual only care as well.
Excellent. Well, thank you so much for your time. You've been very generous with that, and hopefully at least a couple people out there are like, you know what, maybe I need to check on my ticker before I keel over, from an unexpected widowmaker. That was my deal. So, Rich, did you have anything else before we tie up?
No, you just hit on something that I think I need to look into it. My wife, she actually is the program chair at Austin Community College for sonography. And she, studied at University of Wisconsin-Madison and, cardiovascular ultrasound. And the running joke in our house is she likes to do, she's got the mobile where she can put on her phone the transducer and, scan my heart rate, do an echo. And she's like, I just got to make sure you still have a heart. And like, maybe I need to check on mine before I have one of these widowmakers.
Yeah, I think that might be a good idea. So, hey, thank you so much. We'll see everybody next time. And thank you, Dr. Larson. We'll make sure your contact information is in the show notes and in the comments and everything like that. So, U4 Health, Dr. Chris Larson, thank you. Everybody have a great one.
Thank you.
Thank you.